Hello dear patients and our followers. I'm Dr. Ahmedov, hair transplant surgeon from Smart Hair Clinic. Today we are going to do an evaluation of the result of the patient who underwent the hair transplantation surgery in our clinic almost 2 years ago. It was the May of 2022. The patient is 34-year-old white man. He had the mixed type of the hair loss. Every once in a while we can use classification of the patient with the different degrees. The patient had the neurotype 4A to neurotype 5 of the hair loss. The front side and the mid-scalp area hair loss is mostly like neurotype 4A. It means the loss of the continuity of the front hairline, OMT areas in the right and left temples, front forelock, front third, and the mid-scalp. And there is an empty spot in the crown area. So the front and the mid-scalp are closer to the neurotype 4A, and the crown area is closer to neurotype 5 of the hair loss. For this type of patients, on average, you may need the numbers varying between 4 to 5, maybe 5,500 grafts. Of course, number of the grafts vary from patient to patient depending on the size of the open area, the density you want to acquire, expectation of the patient. But the most important criteria here is the capacity of the donor area to give us sufficient number of the grafts to meet the expectations. And most of the time what we see is that for the neurotype 5, or in some patients starting from neurotype 4, depending on the size of the open area, we most of the time may require a second surgery. There can be different treatment options for the a two-step surgery or advanced stage of the hair loss that mostly means neurotype 5, or in some patients starting from neurotype 4. It can be a classic two-step approach when with the first surgery we rebuild the front hairline, cover the front side, and at least the mid-scalp. The idea is to restore the front frame of the face, cover the front side and the mid-scalp. This side is the most visible part of our face. It's almost 60 to 70% of our final outlook. And with the second surgery, at least 1 year later, we cover the rest of the crown area. The second option for the advanced stage of the hair loss may be an option when we evenly spread or distribute the number of the grafts we get all across the head. But this option has one very big disadvantage. When you spread the same number over a very large area, overall density may be lower, so it may not make happy the patient as a result of the surgery. That's the least preferred option from our side, and we almost never advise it to the patient. Or there can be option number 3, when the patient picks up the priority. We have the front side, mid-scalp, and the crown area. The patient may tell us, hey doctor, I understand that we may not be able to cover everything with a single surgery, but my highest priority is, for example, the front side. That's the area that bothers me the most when I look in the mirror. After I finish the front side, if anything is left, my second priority is, for example, the crown area or the mid-scalp, or vice versa between these 3 areas. So there can be different treatment options depending on the patient's expectations. The plan for the patient was the reconstruction of the front hairline, covering the front side and the mid-scalp. We gave the same options for the patient, and the patient decided to go with the two-step surgery. With the first surgery, our highest priority was to cover the front side. His second priority was to cover the crown area, and we have talked with him that with the second surgery, most probably that at least 1 year later, if needed, we'll do a touch-up surgery or some densification surgery to the crown area. So when we designed the hairline for the advanced stage of the hair loss, one of the key factors is the design of the front hairline. For the front hairline, a thumb up rule number 1 for the hair restoration surgery is to keep the hairline conserved. It means slightly higher and slightly narrow to the corners. Why? It gives us the chance to give the patient more coverage and the density instead of just lowering the hairline, because the hairline has some properties like age of the patient, ethnicity of the patient, degree of the hair loss, capacity of the donor area, face anatomy, the height of the forehead muzzle. We also don't want to be too close to the forehead muzzle, otherwise with every mimics you do, your hair going to move back and forth with you. That looks very, very unnatural. Age is very important, as we've mentioned before, because as we men get older, our hairline matures, it goes slightly more to the back, giving us a more masculine or mature look. So when you do the hairline reduction too much or rebuild it too low, if over the time the patient thins a little bit of the hair or loses more hair, we may end up with an island of the hair, thin hair or hair loss area here and here again that may look really weird and unnatural. So the plan was the reconstruction of the front hairline. We kept the hairline slightly higher, covered the temples, rebuilt the front frame of the face. The highest priority was the front side to cover it with the good density. So as you can see from the pictures, the hairline was restored. We marked the areas that needs to be transplanted. One of the most common questions we get from the patients about the hairline restoration is the temple peaks or the sides. Do we do the reconstruction here? Yes, it can be done, but specifically for the young patient or for the most of the patients, if it is not a must, we try to avoid it at the early stage for the same reasons, because these sides may be one of the most rapidly receding sides, and it may look really weird for the patient having a thicker hair here and thinner hair to the back of the head. So the patient went with the mega session, extraction 4,750 grafts. Out of these 4,750 grafts, our highest priority was the front side because it was the biggest affected area. You can see it in the marked zone, and covered the front side with almost 3,900 of it were used in the front side. The mid scalp had a more or less good density. The idea was to keep it the same and add more density to the crown area. So the final number is 4,750 grafts. 3,900 of it was used in the front side because the front side and the front mid part is the area that's visible mostly, and it should be covered with the best possible density for most of the patients. And in the crown area, we made a procedure called sometimes a touch-up or like some densification. When we can do the surgery, in some of the patients, the area may look really open or thin, but when you look from the close range, it's not actually the hair loss, but loss of the volume or thinning of the hair, we call miniaturization. Let's say these are the hair follicles that grow very close to each other. When we can do the surgery, let's say you have lost the hair and there is a gap here, we can do the implantation here. But in some patients, there can be loss of the volume, and it may look that there is some hair loss, but it's actually the thinning. The density or number of the grafts per centimeter square is still intact. And when you try to do the surgery in this area, trying to implant the grafts in between the hair, there is a higher risk you can damage the adjacent hair follicles. So when trying to put one graft, we can damage 2 or 3 of the own of the patient. For these patients, we definitely advise to go with the medical treatment. It's like a puzzle. You have the hair loss, we fit it in. With the hair restoration, we try to cover the open areas as much as possible. And the medical treatment, finasteride, minoxidil, topical, or the oral forms, is needed to prevent further more loss of non-transplanted hair. So that most of the time for androgenetic alopecia especially, they should complete each other. So you can see here the patient immediately after surgery, the front side is covered. There is a very smooth natural hairline with some macro and micro irregularities. We call this jigsaw pattern or zigzag pattern. And then you can see the crown area covered. And here is the patient's dynamics or the change over the time and the final results 1 year after the surgery. Our priority was to restore the front hairline and rebuild the front frame of the face. And you can see the patient has a very natural hairline. Overall density across the front side is in a good condition. So even when he does the hairstyling from right to the left, from left to the right, you can still have a good outlook. Yes, the crown area is slightly thin, as we have talked. The second surgeries or some densification surgery, touch-up surgeries may be needed for some of the patients, but the patient in this way is very happy, and he's planning to have the surgery maybe sometimes in the future, and the medical treatment he's still on. Thanks for listening, stay tuned, and see you in the next evaluation videos.